So we think about the social determinants of health, but we really have to start thinking about the structural determinants of health and not necessarily just attributing it to biology or there's something wrong in the physiology or something wrong with the way our body works. It's really asking larger questions as to why do we see these differences? And we can get into some examples, but I think in terms of reversing it, the first piece is awareness. And the second piece is asking those hard questions as to what exactly are the structural determinants and not just attributing it to biology.
Thank you for that answer, Dr. Singh. And I want to add to that and say that it might be a little bigger than our scope within the healthcare system, but every one of us is a person. And we all have interactions outside of the work that we do. So just like you said, the first thing is being aware that there are people who have no control over the zip code where they live in, and you might interact with them anywhere, in the store, in school, you know, where you teach. Being aware of what those inequities and challenges that they have to overcome is very important. And also being aware of ourselves, because we all have blind spots. And you know, anybody can say, I'm not racist, I'm not ethnicist, I'm not this, but we all have blind spots. So being aware of where our blind spots are, it is this, one of the most striking pictures that I ever saw was a diagram of what it meant to remove inequities, which was, and I'm sure everybody on this call probably saw a diagram like that. And you had these people and somebody had a block and somebody else had 2 blocks to stand upon and a third person had three blocks to stand upon so that they could all look over a fence and watch a soccer match. So that is what we need to be aware of. What do I need to do with the next interaction that I have with somebody so that I don't become part of the problem, but actually become part of the solution?
Excellent, thank you. Essential workers of color, particularly Black, went to work at high-risk jobs early on in the pandemic and beyond. We heard commentary in the film that it became a matter of people who could protect themselves and people who could not, based on what they did for a living. Do you see similar trends in workforce in terms of health disparities and inability to access resources to improve health? And if you do, can you share what that looks like and how your work is helping to reverse that trend?
So absolutely, the facts are the facts, that essential workers, the bulk or the majority of essential workers do come from the same populations that we understand have healthcare inequities. And the reasons are multiple. We can list 20 different reasons why it is that way, but it is a fact. The interesting thing is that essential workers also, we find them in hospitals and in the healthcare systems. So we don't only find them in farms, we don't only find them in the stores or in the bus depots, we find them also in the healthcare system. So when we have facts, there's nothing we can do but accept the facts for what they may be. Unfortunately, having a job and being an essential worker does not translate to having good insurance. So somehow we have to, in our healthcare space, make that connection where people who work, or even people who don't work, have access to good healthcare. I don't know what the answer is, and I suspect that it's not just going to be one switch. We probably have to do multiple things. What control do we have in the place that we work? I want to give a plug to the VA because, you know, once again, data is data. Although we did recognize that there were certain disparities within the VA, within veterans coming to the VA with COVID, it was obvious that certain ethnicities and certain races were more likely to test positive or become sick with COVID. However, the data has somewhat shown that within VA, at least within the work that we do in VA was able to offer similar outcomes to ethnicities and races. That's saying something for what we do in the VA every day. And definitely, perhaps the community can learn something from what we do in the VA.
And no, again, just a couple of comments to add to that. I think in terms of when we're thinking of frontline workers or people that are essential, a lot of this boils down to what we've seen is are we able to commiserate or talk about shared living experiences? And I think the way our society even approaches dialogue has really been a lot of we versus them. And what I mean by that is we don't necessarily see ourselves in the shoes of others because our lived experiences are not the same. And I think that is a fundamental piece of this conversation. So because somebody is working in a different scenario or working in a different, we need to sort of exercise the right to think about, well, what would it be like if I was in their situation? And a very concrete example is, bringing back the point of access. So if you're working in a job where taking time off, you got to do reams and reams of paperwork, or you have to really justify leaving for even an hour to get an appointment to go see your provider, that person's going to have multiple barriers to even going to see somebody when they're sick, right? And a lot of us are in situations where if we're sick, we can probably pick up the phone and get an appointment, virtual or non-virtual, and walk out. And so what I would like to start to think about is, can we actually relate to somebody who doesn't have the same shared lived experiences? And I think that's kind of critical to this conversation, because empathy and understanding starts with sort of recognizing where the other person is coming from. Because we might say, well, why didn't you just go see the doctor? And how many times have we said that to our patients? Like, why didn't you just call? Because that choice that we think we can make very clearly is not exactly available depending on where you work. And we don't understand that. Some of us don't get a chance to really say, is this really a choice thing? Or was this certain barriers that were set up because of an employment situation where you're working in an hourly wage and stuff that you can't necessarily just pick up and take off and go see. So things that we might think like are choices, we need to actually step back and go, was this really a choice? Or have we set up ways where people don't feel like they have choices? And being able to share that or understand that or be aware of that is sort of the first step in any reversal of conversations.
I just wanted to add to that just a little bit, that you brought up some really important points, Dr. Singh, that we fail to think about what that other person might be facing. We forget that a lot of organizations don't offer health insurance. The Affordable Care Act was meant to remedy that, and yet we had huge groups of people who could have benefited from it being very opposed to it because they thought it was Obamacare or they thought it was socialized medicine, not realizing that this was in their best interest, this was going to help them. We as a country have taken a stance of people should pull themselves up by their bootstraps. My family did it. They did it all by themselves. They didn't get assistance. They didn't get help. And we don't pay attention to the fact that the way people arrived on this land is very different. And that those arrivals have had repercussions through centuries. It's still happening. And so we have to pay attention to that. And I've got this wonderful experience of doing private practice and working in the VA for all these years. And I can tell you that often when people even have Medicaid, they can't afford to take off from work because they don't get paid if they don't work. There are hourly workers who have to punch a clock, and if they're not there, they don't get paid. And so those are the things we have to consider as well. But people always say, well, that's their fault. No, it's not quite their fault. And we need to take a different approach to see things change around that as well. So that's my 2 cents. Anything else you guys wanted to add to that particular question? Okay.
No, I think I just, again, to sort of summarize that, whenever we think, I think a simple question we can ask it, because I really like the point that whatever our roles are one thing, but at the end of the day, we're human beings. When we get into a space where we think somebody has made a choice that's different than the one we might have made, I would just implore all of us to sort of think, what actually went into that choice making? Because again, as we are move up in privilege or move up in our ability to make independent choices go up. It's a simple fact. And if I want to do something, I don't really have a lot of barriers that I have to think about. I mean, I have to check in with my family, I have to do, but in terms of societal, there's not a whole lot of people that are telling me otherwise. And I have to remember that that's not the situation for a lot of people. And if we can just start to really think about just that simple fact, and I actually like, just to your point, this notion that our country was built by people who just, were able to lift themselves up from the bootstraps, that's not the right narrative. There were a lot of people who worked behind the scenes for free so other people could lift themselves up from the bootstraps. So that narrative is incorrect to begin with. And we really do need to change that narrative because it ends up changing our mindset. If you think of all the people who are behind the scenes so that people could go do things and not pay, is that really lifting yourselves up from the bootstraps? Or is that taking advantage of different people? That's really the narrative that we need to start it, because I think it starts to organize how we think differently about what choices people have made.
Okay, so for both of you, your work has in the past or currently involves effective training of healthcare professionals to improve care provisions. What are a few evidence-based recommendations you provide to people in the audience who may be working in clinical or non-clinical capacities, but want to advance health equity through their role, department, and institution at large?
That's a great question, thank you. And your question was to evidence-based, but here I am, I'm just gonna do anecdotal evidence for this one. So this is not randomized controlled trials. I'm gonna share an experience that I had. Many of you know that I've had to go through residency twice in my professional career. The second time I was a mature resident, right? So being a mature resident, you are up there and you're watching everybody else in your class, grow up. But I recall that in my internal medicine residency, there was an air both a spoken and unspoken way that we managed patients, different groups of patients. And residents tend to have a resident clinic. It's usually a safety net clinic with people who don't have insurance or have Medicare or lower insurance. And we saw this same disparities, the same healthcare unequal groups came to those clinics. The tone, the words that were spoken by the attendings in the presence of residents, of learners, tends to be language that you pick up as a younger or learning physician or professional, and you can carry that into your practice. Now, like I said, I'm not absolving myself, but I was a much older individual, and being of my particular ethnicity, I was offended by such speech. But I can tell you that it was common speech. It was the way they talked about patients in the ED, in our safety net resident clinic, in the hospital. It was that kind of tone. I saw the patients that got the different types of cardiology referrals, because we had like 3 different cardiology groups. I immediately knew when I came in the morning as a senior resident where each patient was going to be referred to. Nobody ever called me to say to me, this patient's going to this attending or to that attending, but that's exactly what happened. So as attendings, as faculty, as people who are in a position to mold the future, we need to watch what we say and how we treat patients, regardless of ethnicity or race, because that's what our learners learn and carry on into the future. So that's my 2 cents.
That's excellent. That's excellent. Thank you.
Role modeling, yes. I think so this is where I would, to your question, the VA has actually done some really great work in terms of some of the evidence-based practices. And I can say this, we're part of a regional collaborative. And when we look at the VA data in terms of discrepancies or disparities compared to some of the other practices in some of the other institutions, the gap is actually much less compared to other institutions. So then the question comes up, why is that? And I think, you know, again, we're trying to tease this out. This is part of the larger Better Health Partnership conversation. But one of the things that we're starting to see is, of course, you know, as much as we hate them, those system reminders to make sure that everybody is getting the same evidence-based practice, so that, you know, and as much as we hate those reminders coming up and popping up, you know, the clinicians in the room will say, you know, don't give me another reminder. But what's really great about that is it levels the playing field, right? Because you're getting that reminder, the computer is going to send it out to you regardless. And so by following those reminders or following those system things, we actually are providing a very standardized care across the site. And that's actually a very concrete clinical example of how we can mitigate sort of biases and things coming into our conversation, because we can actually say, well, if somebody is a certain age, they're going to need colorectal cancer screening, and we're going to make sure we push the button and we make sure that the process works for them. And so I think those are very important things. And we're noticing that there is the disparity gap in our patient population seems to be less than compared to others. Now, I'm not saying that other institutions aren't working as hard. I just like to think, given the VA's you know, system approaches that are kind of largely agnostic, we're able to provide a standard of care regardless of where the person is coming from. And I think that second piece is there is a trust that our veterans have with our providers. There's, you know, there's always outliers, but I think that also plays a role in sort of seeing some elements of evidence-based practice getting put into practice and actually happening. So.
I like that. And you know, I agree with all that you guys have said. There was a recent study published showing that there is some disparity right now showing up in how VA, or I should say Veterans Benefits Administration, is providing service connection to veterans. And so there's a big investigation that's happening right now on a congressional level. And I think the accountability that the VA has and the scrutiny that it's under helps to kind of offset a lot of the racial injustices that could occur in healthcare. But we have to remain vigilant, and we must not ever move towards denial of it. And I think sometimes our knee-jerk reaction, even with our HRO emphasis and all the education we're getting around becoming a high reliability organization, our first reaction is to become very defensive and then go into denial, not only as individuals, but as an institution. And I think we have to work really hard to really, truly embrace that HRO model and look for areas where we can improve. So thank you for that. I have one final question for you both. And you kind of actually alluded to it with the answer to the last question, but what future opportunities do you see for improving health outcomes for our community?
That's a big one. And so just, I'll start, and I think this is a larger conversation. And again, I want to thank you all for having this, you know, venue for us to talk about it. I think everything from, in terms of we are, meaning the providers and even the non-clinical, when we are working with future generations, as mentioned, we want to make sure we're role modeling that sort of future state that I think all of us agree we need to get to. We're not there yet, but I think we're all in a space where we think that things are not quite where it needs to be, and we've got some work to do. And so really with our conversations, with our role modeling, with the way we you know, discuss issues and clinical things, we can really start to set that stage, look at that future state and start to bring it up. I think the VA, again, in many ways, kind of the way they're looking at outcomes and looking at some of the performance measures and things, are already doing a lot of standard setting. And I think being part of that conversation is a really important one. And then there's, of course, larger systemic issues that might not feel like we as healthcare providers can handle, but I think we need to be upfront in those conversations as well, at least inform people who are, you know, whether it's at a health policy level, at your governor level, you know, how are these structural determinants of health affecting health? Sorry, I know that's a broad answer, but it's kind of getting to all of those levels.
I like that. Yeah,
I think that's a great answer. I really don't have much more to add to that, but to thank you also for inviting me, and thank you for standing beside me today, Dr. Singh. The little I have to add is to be willing to listen. Sometimes we know that what we're going to hear is going to be painful, or we may not be able to deal with it, or we're not prepared for this, or we don't have the time. But just to show that little bit of courage and just lean in and listen. Many times when people who suffer disparities, they know it's not your fault as the clinician. They know that you came in because you came into this job because you want to help and you want to help people. They do know that about you. But if you do not make that connection on the human level, like, talk to me, tell me about this. I know it's not my fault, but I acknowledge that you are going through this. That really sometimes is all that they want to hear. So just a little bit of courage. And I know that all of us who step into healthcare already have that courage. Otherwise, we would not sign up for this. So just, you might be surprised that, pleasantly surprised at the reaction that you get from your patients when you just open up and be ready to listen.
Awesome, awesome. I just want to thank you both for being here today. I know this was a sacrifice of your time, and you gave us such important information. I really am grateful for it. I want to thank our sponsor, Jaleese Thomas. I don't know if you want to unmute, if there's anything you wanted to share. We're in our last minute.
I'd just like to thank you, Josephine, and our panelists and everyone who tuned in to watch the film. Even if they weren't able to make it to the discussion, we'll make this recording available and we'll send that out to everyone who registered. And just thank you for taking that first step, or maybe it's your 10th or 20th step to advancing health equity.
Excellent. Thank you again. Thanks everyone for coming.
Thank you, everyone.
Okay.